Welcome to the Food Junkies Podcast. Here, we aim to bring you the experience, strength, and hope of professionals working on the front lines in the field of food addiction. Our mission is to educate you, the listener, and increase overall awareness about food addiction as a recognized disorder. Here, we discuss all things recovery, exploring the many pathways people take towards abstinence in order to achieve a health-forward lifestyle. We hope to inspire you to thrive rather than just survive. So stay positive, make a change for yourself, and share your journey with others. And hopefully the message will spread.
Does bariatric surgery predispose you to alcohol abuse and even food addiction? Welcome to the Food Junkies Podcast. My name is Dr. Vera Tarman, and I am your host today, speaking with Dr. Jon Davis, a principal investigator of the study, Changes in Alcohol Use After Metabolic and Bariatric Surgery. Dr. Davis is a principal scientist at Novonordisk, where he investigates how gut-brain signaling mechanisms control appetite and associated metabolic disorders. He was an assistant professor of neuroscience at Washington State University. He was interested in investigating the neurobiological connections between obesity, bariatric surgery, and substance use disorders, examining how surgeries may increase the risk of alcohol use through changes in gut biome and brain reward pathways. We at Food Junkies Podcast are interested in seeing if there might be a similar predisposition for sugar or food addiction in our post-bariatric surgery listeners. So, welcome, Dr. Jon Davis.
Thanks for having me.
We always start with the personal interest. What got you interested in the understanding of bariatric surgery and substance use?
Gosh, that's a really good question. Actually, neuroscience did. So what really compelled me in the beginning, and this is going all the way back until I was in college, was I wanted to understand how memories were formed and consolidated and recalled in the brain. I'm actually still very interested in that. But that led me to study brain plasticity. And plasticity was a process that was actually occurring a lot in substance abuse. And so that's how I started to study substance abuse. And I really wasn't thinking about bariatric surgery or obesity or anything along those lines. But then was really fortunate to join the Obesity Research Center at the University of Cincinnati. And there were a number of really well-known, established, renowned leaders in the field. And we began working on projects revolving around bariatric surgery and really how it cured type 2 diabetes or helped with type 2 diabetes. I wouldn't say cured, resolved type 2 diabetes and led to weight loss. And that's how I got into thinking about that, actually.
How did you go from that to substance use? How did you make that link?
It was actually serendipitous. What had happened was we were interviewing patients that had the surgery just to get a feel of if they changed behaviors at all. And some of them said that we actually drink more alcohol after surgery. And so we interviewed their spouses, and their spouses said what they're not telling you is they've had 2 driving under the influence tickets in the last 2 years or year or whatever, and they're about to lose their position. And these were people that were attorneys or that were medical doctors or that were engineers or whatever, that had no prior history of any sort of substance abuse. That was what was shocking to us. And they were mostly in their late 40s thing. And so that's how we got onto it. We stumbled upon it, to be honest with you. We were not expecting that at all. Of course, now the phenomenon's been published widely in multiple well-controlled clinical studies, but what we did is to go back to the lab and see if we could model it to understand if it was true, to get at the biology. And of course, we found that out to be true. Rodents usually don't like alcohol. You have to train them to drink alcohol. But in this scenario, animals that have gone through gastric bypass surgery, when you give them access to alcohol, they immediately drink it. Wow. You didn't have to train them at all. And so it was shocking, actually. And that's how it all started.
That's really interesting. You said that there's a lot of research now that substantiates this, but it's been my experience in talking with bariatric physicians and surgeons that there's still some level of denial about that. Is that passing on, or is that still the case?
I think it depends on, first of all, I would say this. It's not that every single person that has a bariatric surgery is going to go on to become addicted to alcohol. I don't think that's the case. I also think that every patient that's gone through bariatric surgery that had a substance use disorder beforehand is going to stop it. So there's different segments. Yes. And I think it really depends on patient segments. I think it really depends on the psychology of the patient, the genetics of the patient, and really how they came to be in the situation of being a patient living with obesity that meets clinical criterion for the surgery. And in other words, that's a hard question to answer. But what we know right now in the field, what's been substantiated multiple times clinically, is that if you are a low consumer at baseline and you have bariatric surgery, there's a chance that you will develop alcohol use disorder for sure. However, if you are a patient that actually consumes frequent alcohol prior to the surgery, you actually decrease alcohol use after the surgery. Both of those have been published clinically now numerous times. And so the interesting one would say, why? Is that you're saying two opposite things? And no, really what's happening is someone that is used to drinking alcohol every single day, they're very good at titering their blood alcohol concentrations. So they know if they need to drink, if they drink beer, for example, 8 to 10 beers gets them exactly what they want. So they're drinking a prescribed amount on their own every day. But after the surgery, blood alcohol levels are increased because the gut's a major absorptive part of the body. And when you remove a major portion of that due to the surgery, what happens is the blood alcohol is higher. So those patients that used to drink 8 to 10, now they only need to drink maybe 2 beers and they get the same exact effect.
I was going to ask you that question. So it's really true that you don't need as much to get the same effect.
But yeah, I'll continue to try to prove it to you and explain why I believe it to be this way. And so that's the observation, right? And now on the other hand, you would say what's happening with the patients that don't drink? They have no subjective experience of what it feels like to be inebriated with alcohol. And it's also important to understand that for a period of time after the surgery, they're on a liquid diet just to allow for everything to heal. And the way it was described to us from the patients that had this phenomenon was we would be out at a meal with our colleagues while we're on the road for a business trip, and they would usually have a beer for dinner, and we would just happen to have one for any reason. And all of a sudden we had this amazing euphoric sensation. And so they have no idea that drinking one beer, that's not the feeling that we get. A person that hasn't been through bariatric surgery feels that way. And so, of course, it feels good. And they're used to consuming calories in a liquid form. So they then develop a habit of drinking to feel good, which why wouldn't? And they develop alcohol use disorder. And so what we were trying to find is, what's the common thread between those things? And it's like the sensitivity, right? It's the sensitivity to the pharmacological properties of the drug. It has to change somehow. Yeah. So how can we really set out to prove that? And so what we did in the lab was actually test that directly. And the way that we did that was we actually gave animals alcohol that was super low concentrations of alcohol. Like a normal animal couldn't sense or respond. They couldn't determine if this bottle had alcohol plus water or if this had just water, right? They could not distinguish between the two. And we did it on purpose. And then we took animals that had been through bariatric surgery that had no issue. They were just normal rodents, been through bariatric surgery. And those animals actually would start to drink the low concentrations of alcohol.
They more than one. It was.
They knew which one it was. They could sense and detect it. And you actually see the same thing in bariatric rodents with sugar. You give them very low concentrations of sugar, they can sense and respond in a hedonic fashion, actually, at a concentration that a normal animal would never detect. But when you get to the areas where a normal animal can detect and say, yes, this is good, I would like that, it becomes averse to them. So that's one of the theories around the sensitivity to nutrients as well as pharmacologic drugs or chemical drugs, if you will, that seems to be the same. That maybe one of the reasons that patients have lower appetite is that they're getting the rewarding and reinforcing properties with much less, so they can actually consume it and then stop. Certain patients, not every patient. Yeah. Same thing for alcohol. Patients that, in this case, you would be looking through the lens of patients that drink a lot of alcohol before the surgery. Now they don't need to drink as much because they can get the same reinforcing stimuli after just a few drinks.
Before we unpack that, what are the rates that we're talking about? Can you give me some statistics?
I don't think we have good rates on that right now. Yeah, it's not that developed to be able to do that. The thing about the surgeons is they don't follow their patients that way, right? The way to think about this is, I saw that you had questions about the sleeve gastrectomy. The sleeve gastrectomy versus the bypass are very different surgeries. The reason that the sleeve gastrectomy is performed so often is, number one, it's effective. People lose weight. It's very good for that. But it also offers the opportunity for a revisional procedure. If there's recidivism of body weight gain, you can go back and do a functional bypass in those patients, right? And so that's one of the ways to think about it, is that the surgeons are looking for what's going to give their patient the best bang for their buck as soon as possible. But they're not holistically treating the patient. They're not going to follow up the patient for 5 to 6 to 7 years after the surgery. Once they've done the surgery, they come back, they're healed up, everything, okay, you're done. So if the surgery works, great. If the surgery doesn't work and people regain weight, they may never know. So it becomes when you're asking a question about rates, the most important rates that people are looking at right now and have been for the last 4 or 5 years is how effective is the surgery? How many people regain weight after the surgery at 4, 5, 6 years out? That's an important question. And I think we're seeing studies now, and have over the last few years, come back that have estimates of between 30 and 50% of patients that have these procedures regain all their lost body weight.
Yeah.
So I think those are the numbers I've seen. That doesn't mean that's what the actual numbers are, but we have far less information on the patients that are potentially consuming, an illicit substance. Can
we go now back to the unpacking the sensitivity angle? So please go on.
It could be a multitude of things, right? And if we just start using the sensitivity example, so there's 2 ways of thinking about it. And I think we should not say food on one hand and alcohol on the other. So the mechanism of alcohol is obviously different than food. Alcohol works on GABA receptors in the brain. It can directly interact with GABA receptors in the brain. It gets into the brain, for sure, no doubt about it. Food, on the other hand, is basically digested. It goes into the gastrointestinal tract, and then those nutrients, as they're being absorbed, either fructose or glucose or fats or proteins, those are initiating gut hormones to report back to the brain and tell the brain, okay, you're getting full, you're getting more full, stop eating, or you have enough calories, or you don't have enough calories. All of those things are happening in terms of, nutritional regulation. So when it comes to alcohol, it's clear that in rodents and humans, there's higher blood alcohol after the surgery. And that's just basically from restructuring the gut. When you remove the duodenum of the small intestine, which is a major absorptive part of the gut, a lot of the alcohol can't get absorbed. It's in your blood. So it's pretty simple. If you use the food analogy, what happens is there's a gut hormone called glucagon-like peptide 1, and it's secreted from the jejunum. And the jejunum in the bypass surgery is actually stretched all the way up to the stomach, right? So it's not used to seeing nutrients that soon and in that form. Usually there's a whole highway of duodenum it has to go through to get to the jejunum. And so what happens is in that condition, you have huge excursions of GLP-1 when you have mixed nutrient meals. And GLP-1, one of the things it's doing is it's going to your brain and it's telling you you're full, stop eating, you're full, stop eating. It's
a satiety hormone.
It's a satiety hormone. It does other things, actually. Actually, one of the things that it does, and this is me trying to answer your question in a roundabout way and give you the most information I know on it, is that GLP-1, in addition to being a satiety hormone, we know that it also is involved in other CNS disorders. We know it's involved in addiction as well.
Yes.
GLP-1 will turn down alcohol intake. It will turn down cocaine intake. It turns down food intake. And so in the situation of the person that had high alcohol use before the surgery, that undergoes bariatric surgery, that then stops, you got 2 things going on. You have the alcohol being high concentration in the blood, but you also have increases in GLP-1 when they consume alcohol, right? Because GLP-1 will alcohol will augment GLP-1 in the blood, just like food does. Not to the same degree. It's nowhere near as strong, but it will. And so that's a potential mechanism. And we actually in the lab discovered that. We actually discovered that if you give GLP-1 like drugs to an animal that is genetically predisposed to have alcohol use disorder, it reduces their alcohol intake. And so it could be that that's one of the reasons that patients stop, in addition to high blood alcohol. But what would make them start? And you mentioned ghrelin. And so ghrelin being the opposite of GLP-1, it goes up when patients are food deprived or when they're really hungry, and acts in the brain to stimulate appetite. But it also stimulates intake of chemical drugs like cocaine, alcohol, for example. And so
you're saying that when you're hungry, we say this in the community all the time, that hunger is a trigger for other drug use. This is the mechanism.
I don't want to go that far and say that's the mechanism, right? It potentially is one of them.
Okay.
So when you get into an addicted patient, it depends on what they're addicted to. So if you look at most patients that are abusing psychostimulants, they don't have excess body weight. In fact, it's the opposite. If you look at most people that are struggling with alcohol use disorder, they're very metabolically compromised, for sure. They're not getting a lot of nutrients. They're not absorbing nutrients. Their gut, they have systemic inflammation. So there's a complete different internal milieu in an addicted state versus an obese state versus a normal state. But when it comes to the basic biological mechanisms, we know for sure now with GLP-1 drugs, incretins that are out on the market for obesity, there's a lot of reports that the patients will say, we don't crave alcohol as much anymore. Well, we don't know how it's happening. We don't believe that GLP-1 drugs are getting deep into the brain, the parts of the brain that control alcohol disorders, but indirectly they're somehow influencing that. And so then to get to your question about ghrelin, what would be the mechanism of driving in the first place? Most addictive disorders develop during adolescence. And so it's probably genetic and also the environment that they're in, right? The attachment style. There's a lot of things that would make an individual, consume more or less chemical drugs. But biologically speaking, if you give ghrelin to an animal, it will augment its ability to seek out food or chemical drugs. In other words, if someone is using drugs all the time instead of food, and they've chosen, if you looked at addiction as a pathology of choice, I'm going to choose drug over food, then it's possible that ghrelin could be that cue that's helping them understand when they're going to have availability of the drug, right? Because ghrelin also is a predictive cue. It will go up before animals get food. So animals that are binge eating have a huge excursion in ghrelin right before they have their binge meal. So that could be a potential neuroendocrine / physiologic mechanism that's driving people to consume more illicit drugs. But I wouldn't want to say that's the only thing, right? It's more of a way of saying that physiology is setting the tone for the way the central nervous system is behaving based off of internal motivational states and those sorts of things. So it's a very powerful thing, but it's definitely not the only thing.
Would it be fair to say that bariatric surgery and GLP-1s do a lot of the same metabolic changes?
Yes, they're very similar. They're very similar. In fact, you have improvements in blood glucose, you have improvements in appetite, you have body weight lowering effects, very similar.
Could we then say then that the person who's using a GLP-1 is also potentially predisposed to alcohol increase?
No, because it's different, right? If we identify that one of the common features of bariatric surgery is you have increased GLP-1 after you've consumed a meal, but a bariatric patient is very different in one key way, right? They have a rerouted intestine. So if they're drinking alcohol, they're going to have high blood alcohol. Someone on GLP-1 is not going to have high blood alcohol. They still have a normal intact GI tract.
Could a post-bariatric surgery lay the conditions for more absorption or more hedonic effect of sugar?
So it's an interesting question. I think what you're trying to ask is, if you have bariatric surgery, are you going to be predisposed to consume more or less sugar? I think that's what you're asking.
Yes.
And the best place to start to answer that question is if you actually look at rodent work on bariatric surgery and you look at what happens when you're just infusing tastants into their mouth, right? So just the sensory processing, if you will, of hedonic responses for sugar. And what happens there is the animals actually can sense and respond to very low concentrations of sugar that they usually wouldn't.
Yeah.
A normal animal can't detect that, right? So what that's telling you is that maybe one of the ways that appetite is reduced for sugar after surgery is that you have an increased sensitivity for the sugar. That's different than saying, is there a hedonic change in the brain? Meaning, do you want or like sugar more or less? That's different. Those psychological constructs, the wanting being the dopamine arm, the liking being the opioid arm, those are very different than being able to the sensory detection of something, right? Yeah. They all work together. That said, place to start to think about your question other than the sucrose sort of sensitivity is if you look at brain dopamine.
Yes.
Look at the wanting. And so historically what we see in patients living with obesity is they have low brain dopamine. And there's this opponent process theory that states that basically patients living with obesity will consume more palatable food to get dopamine from a low baseline back up to normal baseline levels. So it becomes this vicious cycle of trying to overconsume palatable food to feel normal again, but you never can overshoot this low baseline. And further, what's also been published also fairly recently is that if you take obese patients and you reduce their body weight with diet and exercise by 10%, they still have the exact same low dopamine in the brain, and specifically when you're giving a meal. And so what that argues is that there's something about low dopamine that's defining a CNS disease state in an obese patient. That doesn't mean every single patient living with obesity has that. It's been shown time and time and time again for over a decade now that this is the case. The question becomes, if you take a patient and you put them through bariatric surgery, can you restore dopamine in the brain? There's some evidence that the answer is yes.
Oh.
And so that could be a neurochemical angle to what's explaining the increased sensory detection and the reduced appetite, because we've known for decades if you give things that stimulate dopamine, like psychostimulants, amphetamines, they reduce appetite. Bupropion and naloxone Contrave, it's a 2014 FDA-approved drug for obesity. It increases dopamine and norepinephrine, also blocks opioids, but it increases dopamine and norepinephrine in the brain, and it reduces appetite and body weight. It could be that accompanying or attendant neurochemical change that happens after bariatric surgery is also leading to reduced appetite, i.e. reduced palatable food intake. But again, this is not like a blanket that you can just say one size fits all. Right? You just can't do that when you're dealing with patients, because one size doesn't fit all. They're all patients. They're all people. They all have families. They all have different backgrounds. And all of that shaped the way their neurochemistry is.
Okay, so summarize, obesity seems to be associated with low dopamine threshold, at least beforehand, and that the surgery seems to correct some of that so that not only do they have an increased sensitivity to food, but also they don't need to achieve such a high rate because they're already high to begin with.
Exactly. They already feel good. Exactly. Yeah.
Right. And the surgery does that, and presumably the GLP-1s do too somehow.
Maybe. We don't know that yet.
Yeah.
We don't know. We don't know what GLP-1s are doing to dopamine.
Okay.
We don't have that answer yet. Good questions. All really good questions.
Yeah. Now, what happens with over time with post-surgery? What you've just described happens initially. Does that sustain itself?
Yeah, in post-bariatric patients or in rodents?
Yes.
Yeah.
How it changes over time. I'm assuming appetite does come back. Satisfaction with eating does seem to come back after year 3 or year 5.
But yeah, I think that there's actually published reports on this, that there is hedonic cravings that come back, in particular after sleeve gastrectomy, within 2 to 3 years after the surgery, and that the ratings and pleasantness and desires and food motivation and power of food scale sort of questionnaires seem to indicate that the patients do have renewed craving for palatable food, which if you think about it, it's amazing. It's amazing that you've restructured the gut and people can ever gain any more weight ever. Like that to me is amazing that you can do that. But at the same time, it's not super surprising because food is the main energy source we have. And so compromising your ability to get the energy source is a bad thing. That would be not good for survival. And hedonics and palatability is one way to orient the organism to motivate behavior to get that food. So if you're in a situation where you're losing a lot of body weight, you get to a certain point where you have counter-regulatory physiology like ghrelin that kicks in and says, hey, wait, Vera, you've lost like 200 pounds. You need to start to eat again. And then you start to fight physiology. And of course, ghrelin is going to make you want to have appetite, and you're going to start paying more attention to cues in the environment that signal the availability of food. Yeah. And generally, you would want something palatable because that would liberate calories faster than something that has lower calories. So I think that for any procedure you do, you want the situation where a person actually can consume palatable food, because that's a spice of life. You don't want to be like, you can never have, for me, it would be Reese's cups. You can never have a Reese's cup again. That would be terrible. But instead of eating 4 or 5, you just eat 1 and that's good. That's all you need. So I think that's the situation you want. I think the area where we're at right now is we don't have great solutions. The surgery is one of the best solutions right now. Incretin therapy is another non-surgical solution. I don't think we have enough data to know whether there's going to be cravings that come back. In the bariatric world, that's been around longer than the incretins. And so in the bariatric world, there are reports that there is recidivism of body weight gain and food cravings, for sure.
This is just the body's homeostatic compensatory, like you were saying, measure.
Exactly. Yeah. Exactly. And so I would say that for any pharmacology, it would be just the same, and maybe it would happen even faster, because bariatric surgery is like a sledgehammer. You're physically restructuring the gut. You're not doing that with pharmacology. Again, still too early to tell and to understand if that's the case or not. And it could also be in a segment that's more predisposed to X or Y that you see this. And maybe in some patients, they're like, this is completely fine. I've never had a food craving again on incretins or bariatric surgery. I'm sure there's patients that experience that, which is the intended purpose of the surgery.
Maybe the people where it does come back, they're already predisposed to some sort of addictive hedonic pathway already. It's predisposed. And so it's harder to escape.
It could be. If it's psychological in nature, which I would say most addiction is, it has to be. You have to make a choice. Eventually you have to make a choice, which means psychology is involved. Then it's a little bit more difficult, even though you have strong physiology pushing you one way or the other. You have to make a decision on what you're going to do. The really good example of this is anorexia, a very serious eating disorder. Far too many people die from this all the time. In that situation, you have patients that are cognitively overriding all of the physiologic signals telling them to eat because they have to live. They're able to do that, right?
Yeah.
And so if you have the psychology is set up in the right way, even though it's detrimental, you can override physiologic signals that tell you to stop eating, and that is going to make you become obese, that will tell you to eat and you're not going to, that will make you anorexic, or that will tell you don't overconsume this chemical drug anymore. It's bad for your liver. It's bad for you, but you still do it. And so that's a key component. And unfortunately, every single patient living with obesity does not go through a psychiatric diagnosis. They go to their general practitioner, if anything, right? So we don't have good histories on every single patient, every single thing that they've done in their life up until now, how they got here or what they're doing. You'd have to have surveillance on them all the time, and that's just not how our world works.
A question to go back to that homeostatic compensation. If a person were actually to lose weight less drastically, but very incrementally, maybe there wouldn't be such a pullback to get back to the weight that you were originally.
Yeah. So if you're losing, weight naturally, even maybe one could say, with like diet and exercise, would you still? I think the same thing is true, right? A lot of people that diet still rebound. You know? It's a very difficult thing. It almost seems like it's a complete lifestyle change that has to happen.
For sure.
There has to be some really strong mystic change in the brain that makes a person really want to adhere and stick and completely change the way they have a relationship with food, in this case, to sustain that. That's my feeling. And I think that's what everybody wants to go for. And what you suggest is an excellent way to start. Slow quality weight loss over a longer period of time. From the outside looking in, that's a great idea for the patients. Patients would say yes to that. It feels good. I don't know if a company would say that. I don't know if an insurance company would say yes to that. They're going to look, how much weight do you lose and how soon do you lose it? Because they're only going to pay for a certain amount of time, period. So it depends. You're trying to appease the patient and the payer and the provider. It's a lot to work with there.
Right. In the food addiction community, where I'm coming from, we are advocating diet and exercise, or what we call it lifestyle and exercise, life change and exercise. And what we do see is people do lose drastic amounts of weight, but it takes a long time. The good news is the weight regain, should it occur, also takes a very long time, and it's very minimal.
Yeah. And I think that in that situation, my suspicion is those individuals have been able to relearn and reestablish their relationship with food. And I think that's key and that's critical. A pharmacologic drug or a surgery is, although biologically very strong, they don't necessarily have the power or the staying power to help you reframe your cognitive emotional approach. That takes coaching and interacting with people. That's a very different thing. It's turning the biology up or down.
So getting back to your study, can you apply any of that information to the concept of sugar or food addiction? First of all, do you buy into that concept? In the study, there was some hesitation to say that we should call it an addiction. Can you elaborate a little bit on that hesitation and your thoughts?
I think you want to be, especially when it comes to patients living with obesity, you want to be really careful about labeling the cause or the rationale as something that has to do with motivation or willpower, right? I think that's the first thing, is just to be very cognizant and aware of that. That said, the first sort of DSM-4 entry that related to food at all was binge eating disorder. And the binge eating disorder has all the signs and symptoms of chemical addiction. And is it true that there are patients and people in the world that, have excess body weight, that are living with obesity or not, that experience things that resemble chemical addiction with food? Absolutely. It's called binge eating disorder. There's a clinical diagnosis for it. You have to see a psychiatrist to get diagnosed. So yes, that's true. 100%. There's no doubting that. But if we go into a whole, worldwide population of patients living with obesity, how many of those patients actually are clinically diagnosed with binge eating? Some estimates say as many as 30 or more percent. That's a tremendous amount of people. We also know that patients living with binge eating disorder actually, don't always get diagnosed. They don't always go see a psychiatrist. They may not even know they have. So perhaps it's an underestimate. Maybe it's an overestimate. We don't really know. But that doesn't mean that there aren't patients that have understood that we need to change our dietary habits, our nutritional habits, that we need to eat in this sort of frequency at this time of day, consume this amount of water, get this amount of sleep. They're doing all of those things and they're adhering to it, and that still can't lose weight because they have a slower metabolism, a reduced energy expenditure due to the physiologic condition that they're in. So you don't want to go tell someone that's literally doing everything they can and they're super highly motivated that you got food addiction and that's why you can't lose weight. So to me, what it comes down to is that there's different segments of patients living with obesity, and you do have patients that are doing everything they possibly can to lose body weight, and it's just not working for them, and that's due to some physiologic metabolic mutation in their body, versus people that have a psychiatric condition that's predisposing or maintaining that obese condition. And I think they're different.
I would agree with you. What you're calling binge eating disorder, we usually call food addiction. The DSM definitely has the binge eating disorder, and we're actually saying that it's probably actually food addiction. Basically, we're talking about the same thing, that there's an addictive psychiatric component to the person's eating. We would certainly agree with you that not everybody who suffers obesity has that. In fact, our numbers are closer, like you said, 30% for binge eating. We say maybe as high as 40 or 50%. That does mean that there's at least 50% who don't.
But I think it becomes a matter of, at least from my perspective, is how can we identify who's who, and what are easy strategies for that, and then what are our interventions that are going to be safe and effective for those patients. And seemingly you would want to have some sort of cognitive behavioral component, and maybe together with a pharmaceutic, maybe together with some digital intervention in the future that can sense and respond to times in which an individual may be more or less predisposed to have an episode of overeating. I think in the AI and every world that we live in right now, I can see something like that happening in the future, where it's really dialed into that particular person. Because everybody's different, right? Everybody sleeps differently, drinks more or less water, likes different foods, but almost like a personalized plan within different segments of obese patients. I think that would be really cool to see in the future.
Can you elaborate a little bit on that clinically?
Yeah, so I guess the place to start is that the energy balance equation is really where you want to start. It's calories in and energy out. And the only way that you're going to get an obese phenotype is if there's excess calories and less energy expenditure, period. Unless we don't believe the laws of physics, there's nothing else that can explain that. What I'm saying is that to become obese, there has to be an imbalance. Period. That said, that doesn't mean that the patient that maybe suffered from an imbalance early on in life for whatever reason, it could have been food scarcity. That could be a predictor of onset obesity in adolescence, for example, something of that nature, that they don't realize, oh, wait a minute, this is a huge portion size, I shouldn't be eating this, or this has got too many calories, I shouldn't be eating this, and dramatically change and understand that and still have a difficult time reducing body weight, right? That's a different situation. In other words, when we're now starting into the realm of like obesity prevention. How do you stop somebody? And then the question is, how do you identify them in the first place? And when? Is it a genetic screen? If so, what are you screening? And when, is it the pediatrician that's doing that? Is it a family history? The parents or someone in the family had CVD issues or obesity issues? That could be the case. Is it some other endocrine signal in the blood that indicates that they have a high appetite or something of the like, or a combination? I don't know what it would be, but you somehow have to figure that out so that then you can actually have that personalized plan for those individuals prior to developing obesity. Or you do what's happening now. You just start with the obese patient. We don't know how they got there. We just know we want them to lose body weight. And that becomes much, much more difficult, right? Because you're just treating everybody the exact same way and hoping that it all works. And we know it doesn't.
Getting back to your study and the idea of alcohol consumption, should we pre-screen people before surgery for alcohol consumption and maybe suggest to them that they should not drink at all? Like, should that be part of the protocol?
In some cases it is. I don't know that every surgeon subscribes to it, but in some cases it is. When I started working on this, and this was decades ago, you had to lose 20 pounds, you had to be behaviorally compliant, you could not be on antidepressants, you could not have a history of substance abuse disorder, or you couldn't even you would be excluded. You failed to meet criterion for the surgery. I do not know how that's evolved since then. Yeah. And this is going back, 2012, 2014, but I'm assuming that it has. But in reality, the situation is you have patients, less than 1% of patients living with obesity will get a surgery or use a pharmaceutic of any sort, right? Mm-hmm. That means like 98 to 99% of the population is seeking nothing. And no one knows why. So when it comes to bariatric surgery, people that are willing to go through bariatric surgery, they've made a choice. They really need to do this surgery. And so it's like they're in a situation where it's starting to become very dangerous if they don't have an intervention soon. Yeah. So what I would say, is it really fair to that patient to then stop them? In other words, is it worse that you're going to live another 8 to 10 years and then die 5 years later from alcoholism? Or would you rather not right now?
Yeah.
There's a chance you're not going to have any problem with alcoholism either. But to your point, is it fair to talk about that before the surgery? Hey, you may have issues with alcohol use after surgery. If so, this is the resources you should go after, and here's how you should do it. Absolutely.
Yeah, to encourage them to extremely moderate or just don't drink.
Yeah, try not to, just don't drink, period.
Yeah. You mentioned that in terms of gaps in research, we need to get more clinical research actually to see what happens at the 3-year mark and at the 5-year mark.
Yeah, so those studies are very expensive to do.
Yeah.
And when I was doing this for a career, and one of the issues that we would always run into is you have the people in the alcohol community that are funded by the National Institute of Health. And it's a very small community with very limited resources, extremely limited resources. And then you have the community just working on metabolic disorders, and it has a lot of money, and there's a lot of people working in that. And you would think that there's a lot of crosstalk and that it's easy to actually say, oh, I've observed there's this thing that happens after bariatric surgery, and it's actually maybe killing people because it causes them to drink too much. Alcohol Institute, I need money for that. No, that's not how it works at all. It's very difficult to get the Alcohol Institute to actually fund what they would call metabolic research. So unfortunately, our system to fund really interesting research that's innovative that could lead to uncovering a lot of new biology is not set up. It's set up to fund things that are prioritized within those institutes. And that's how it is. So when you have these serendipitous findings, you got to get lucky to continue to do the work almost.
You did mention that there is a lot of research on the success of bariatric surgery. Can you give me some figures offhand about what the success rate is?
I don't know figures off the top of my head because they change so often. The figures that I remember looking at recently is that between 30 and 50% of patients undergoing sleeve gastrectomy regain body weight. That's the figure that I
After
remember.
about 5 years, I think, right?
Yeah, but what the success rate initially is, I don't know. And I think it just depends on how long they were looking, and that's pretty much it. But there's tons of research on it, but it's probably frustrating because, again, they're not all set up the same way. They're in different cohorts of patients, and maybe the length of time studied is different. And so it's tough to say that what exactly is the success rate. Is it 80% of people that get it are successful for life? I don't know what that number would be.
If you could, let's say you had money suddenly and you were able to do more research, like where do we need more research in this area of post-bariatric surgery and alcohol?
Yeah, great question. One of the things that I would have done was to start looking into the central nervous system mechanisms that change after bariatric surgery. Just baseline, what happens to brain dopamine. We did a lot of work on the brain dopamine system in bariatric animals, but we had just got to the tip of the iceberg, honestly. And there's new tools and techniques out now that would allow you to really understand neurons that become active or inactivated in certain parts of the brain that we know control appetite with and without bariatric surgery. So that's probably where I would start first, is to try to understand what's happening at the level of the brain after the surgery, and then start to layer on now what's happening in the context of giving alcohol or a palatable food or a combination of both. And then finally, what I would want to see is whatever changes that we found to be different, how long do they persist? Is this something that happens over the first month or two, or is this something that lasts the lifetime of the animal or whatever? And then I would also want to have a translational arm so that I'm doing this in patients. And so there I would want to do longitudinal MRI studies in the post-bariatric brain. So 1 year, 2 year, 3 years, looking at food cues, chemical drug cues, those sorts of things. And at the same time, monitoring the patient's BMI. Have they gained more weight? Have they stayed the same way? And giving them also probably some sort of digital intervention, or not intervention, but digital measure. So I would want them to wear something that would report back at all times what their eating behavior was.
Yeah.
Right now we only have surveys. We don't know what they actually eat. And so there's continuous glucose monitoring that could be done now. But so in other words, really strongly link what you're seeing in the preclinical space with what is happening in the clinical space. And there's going to be some things that don't translate. That's okay. But the ones that do are the ones that you really want to start to focus on and understand, what's that process doing? Is this turning up preference for something? Is it increasing sensitivity? Is what's actually happening? But that's how I would have set it up, basic, but also with translation in mind. And what I'm describing is a very expensive thing to do, right? Because when you recruit patients, you're paying them a couple $1,000s per patient. When you're using fMRIs, that's expensive. But if you really want to figure this out, that's how you need to do it.
Yeah, and it would really mimic the clinical reactions that people are telling us. Eating changes post-surgery, and then over time it changes. And this would be a way to understand the mechanisms of that.
Yeah, exactly. So that's basically how I would do it if I had unlimited funds, and I would recruit all of the people that are really good, which there's several psychologists that work in this area. There's some folks that I know that do fMRI that are very good, and also basic scientists, and get all of these folks in the same team together. 8 minds are always better than one. And so that we're looking at the right things and drawing off of all of their experiences and studying these things as well.
Okay. In closing, getting back to you, what is up next for you, or what are you doing now that's interesting for you?
What I'm doing now is I'm trying to understand what's the next new drug to develop to help people living with obesity. And that's what's next and new for me. And of course, all that's confidential, so we can't go into details or mechanisms or anything like that. But yeah, so I left the academic world. In fact, my last student defended her thesis, her dissertation, in July of this year, and the lab shut down a couple months ago. But I had been working with a pharmaceutical company for the last 4 years, and the lab was still going. They allowed me to help my students finish, which I thought was really cool. But yeah, now what I'm doing is taking all that knowledge that we discussed today and trying to leverage it to help patients living with obesity and come up with affordable, safe, effective treatments that can help people reshape their relationship with food And so they feel better, number one, right? That's what we want. And then have an improved quality of life, and that they're healthy, and that they're happy. I think that's my goal. And those are tall orders. That's going to be a lot of work.
You're with an area where there's more money than in academic research.
Yeah. We don't have to ask for money. It's not how it is. In fact, it's the opposite now. All the academics that I worked with, I can give them money.
Without saying anything, we've got Ozempic, or the GLP-1s, and the latest version now, Mounjaro, which my understanding is it includes the mechanism that Ozempic uses, but with an additional piece. And so is the work that you're doing adding yet another dynamic on top of that? My guess is that these drugs are all going to tap onto slightly different manipulations of different hormones.
That's the hope, right? I think that's the hope, that in the future we come up with new mechanisms of action.
Yeah. So when one becomes tolerant, you can move to the next.
Yeah. And it's not just about, from a drug discovery point of view, it's not just about let's give somebody a drug and then after it stops working, let's just give them another drug and another drug. Like, that's not the concept, at least at our company. We really think about the patients first. So we would love a situation where we were giving the patient, a treatment for 6 to 8 months or a year or so, and then they're cured. Or we could prevent obesity from ever happening in the first place.
They wouldn't have to be on it the rest of their life. Like a drug could do it.
Exactly.
Wow.
Yeah, we would love to do that. The problem is we don't have, and I say we, the entire industry doesn't have anything like that right now. So our job is to actually build off the incretins that you mentioned and understand, obviously, their success, but where are they failing and why are they failing there? Yes. And how can we get better? And is it a different mechanism of action? Or is it something we can tweak within that mechanism? Or what do we do? But generally, it's like sticky knowledge. You want to teach somebody about diabetes, you start out asking them, do you know what sugar is? And, tell me about that, instead of insulin receptor substrate and get super technical and complicated. You want to start with what works and then add on to that. And then hopefully within that journey, you can figure out some new information that will help you create a safe and effective and well-tolerated treatment that everybody can have access to. Because again, that's the other really key point of this, is that we know a lot of people don't have access.
Yeah.
It could be due to refrigeration. It could be due to knowledge. It could be due to, we don't know why. We really don't know. Those are just some good examples, but that's the key, is in the obesity game right now, you want to be able to help the masses of people, and it needs to be cheap. They need to be able to afford it. That's something that's very much on the forefront of our minds right now.
Last question, our signature question. If you could tell a younger version of yourself something about the work that you're doing now, or the work that you were doing with the alcohol, what would it be?
Keep an open mind. That's what I would say. And I feel like luckily I did that. I always followed the science. I didn't come in with someone much wiser than me told me one time, there's two types of people in science. There's people that test a hypothesis, and there's people that ask what if. And I'm much more of a what if person. And so I feel just following the data and then trying to understand what else happens, what if this happened, what if that happened, is the way that it's fun for me, and the way that I learn the best. And so I would just encourage my younger self to continue to think that way, and don't worry about the mathematical hypothesis X, Y, and Z, even though there's a lot of validity to that, and I do it all the time and every single day. And I understand that. I'm still more of a dreamer.
Thank you so much for your time to talk about this with us.
Yeah, anytime, Vera. Thank you so much.
Thanks for joining us this week on Food Junkies Recovery from Food Addiction. Make sure to join our Facebook group, Sugar Free for Life Support Group, I'm Sweet Enough. Molly and Clarissa are food addiction professionals who offer one-to-one counseling and group coaching through Sweet Sobriety. Please subscribe to our show so you never miss an episode. While you're at it, if you found value in today's episode, we'd appreciate you leaving us a review on your favorite platform. Your feedback helps grow our show and allows us to reach others who need to hear this message of recovery. Don't forget to pick up a copy of Dr. Tarman's book, Food Junkies. And as Vera always says, the power is ours.